Hello everyone, myself Dr. Namrata Vithlani. I am practicing as a physician in Indian Semester in Surat. In previous video, we discussed about the aortic regurgitation, its introduction, basic pathophysiology and clinical symptoms. In this video, we will discuss regarding the various etiologies for aortic regurgitation and what is the difference in the clinical presentation of acute and chronic aortic regurgitation. So if we look at the etiologies for acute AR, they include aortic dissection, trauma, infective endocarditis. And etiologies for chronic aortic regurgitation, we divide into two: the diseases affecting the aortic wall cusp and diseases affecting the aortic root. So the diseases affecting the aortic wall cusp, that include the bicuspid aortic wall, calcific degenerative involvement of the valve, and rheumatic affection, out of which in the females rheumatic involvement of the aortic valve, it is much common. In the young individuals, bicuspid aortic valve, it is common, and the elderly calcific degenerative involvement is common. If we look at the diseases involving the aortic root, they include the chronic long-standing systemic hypertension, various connective tissue disorders like SLE, Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, syphilitic aortitis, and giant cell arteritis. So these are the various etiologies for acute and chronic AR. Now, what is the difference in the clinical presentation and severity? So, acute AR, in acute AR, what happens is there occurs the backflow of the blood from aorta to LV during the diastole. So, the systolic blood pressure rises and diastolic blood pressure falls. This is true for both acute and chronic AR, that there is higher systolic blood pressure and lower diastolic blood pressure. So there is a wide pulse pressure. So whenever there is a backflow of the blood in the diastole from aorta to LV, there is increase in the end diastolic volume. In chronic AR, what happens is, to accommodate this volume over a period of time, LV hypertrophy occurs. But in the acute AR, the LV has no enough time to accommodate the volume. As a result, the back pressure changes and the pulmonary congestion, pulmonary edema, and if untreated, it results in the decreased cardiac output, stroke volume, and cardiogenic shock. While in the chronic AR, due to the backflow of the blood from the aorta to LV, increase in the end diastolic volume, there occurs the eccentric LV hypertrophy, and over a period of time, if it is untreated, it results in the pulmonary congestion. That is a very late stage. While in the acute AR, occurrence of the pulmonary edema, it is very early, and these patients are very sick and they need the prompt surgical correction, otherwise the mortality remains high. So in the acute AR, early surgical prompt intervention, it carries the high mortality. While in the chronic AR, if it is detected early and operated early, the prognosis is good. So what are the prognostic indicators in the chronic AR also? That depends. There are various echocardiographic findings there, such as LV size, LV end diastolic volume, ejection fraction. So these are the various prognostic indicators. We have to detect early. If patient is asymptomatic or mild to moderate symptoms, we have to follow up these cases at 3 to 6 months, 1 year, and look for the various dimensions and progression of the disease. If any surgical indication is there, then we need to correct accordingly. Thank you.